Hi, Dr. Pelto here. I want to thank you for looking at this video about podiatry in relation to primary care. This is for you if you're a patient and you want more information about your foot condition, but more appropriately, this is a grand rounds lecture that will be done for primary care doctors. That would be both family practice and internal medicine doctors that see foot conditions every day, and they want to know when to refer them over appropriately. Basically, what I'm going to do here is I'm going to show you some of the most common things that are going to come into your clinic, and these are also the most common things that people deal with. And we will go over what you can try before you go to see a specialist, and I'll go through that. It'll be quite quick and objective. For those, since this is a lecture, there's no disclosures here. I'm doing this just for the educational purpose for those that are watching. We're going to go over the most common foot and ankle conditions and the initial treatments prior to referral specialists. I'm not going to go into the detail of what we do in the office, but you'll see them kind of delineated. And the method we're going to do is I'll go over one at a time, starting with the most common things, and then there'll be a checklist. And I really like using these. I use these in our office all the time. And the ones that you could do prior to going to see a specialist would be underlined. That would be my thought. If you want to download the presentation and the video, just use a QR code and you can scan this. It's pretty easy to do that. Then you can look at some of these slides if you like to afterwards. So these are all the conditions that we're going to go over. They're in alphabetical order, and so when you look at the slides, you can click the link and go to the appropriate one, whatever one you're interested in. But I'm going to go over really the most common ones that you're seeing, or that I see people come in from the primary care. So let's go into it. The first thing is we're going to talk about plantar warts. Warts are a growth that usually happens on the bottom. The reason we call them plantar warts because they're on the bottom of the foot in the plantar aspect. They have blood vessels that go into them, and they're kind of living on the bottom of your foot as almost like a parasite. It's sitting there. Your body doesn't know it exists. Here's an isolated wart, and what you can really tell is little black dots here. This helps you determine that it is a wart. Here's a bigger one, which is called a mosaic wart, and that bigger one is very challenging to treat. Here's one that's painful on the outside of the foot. They tend to be over weight-bearing surfaces, and that's why they're quite painful. Here's a review article if you wanted to look at it, but I want to go over the treatment options. These are the treatment options that I give my patients in the office. I don't usually start with surgical removal, but if someone only has one wart, sometimes I will remove it. And that's really the quickest way. People that, for example, have don't have insurance or really high deductible and only have one wart, we might remove that. Basically, the number of visits is the surgery visit plus 2 or 3 post-op visits. It hurts, and there is a concern of scarring or of recurrence afterwards. That's kind of the issue with removal. What we typically use in the office these days is either Cantharidin, okay, or laser. So those are the two options. What Cantharidin is basically Beetlejuice. That's what we call it. But it's a blistering agent. The benefit is that when you come into the office, it's not going to hurt you, but when you go home, it will hurt, and it tends to hurt for up to a week. It can be painful, and it works quite well, but it's a number of visits. If you notice, I put 5 visits. This could be a lot more than that. I wish there was a lot quicker way. I really don't know a quicker way, but this is what we use and what works really well, and we see all the difficult warts that are coming in that other people are using either a salicylic acid or they're using liquid nitrogen or something else like that. Laser is, so Cantharidin hurts afterwards. Laser hurts in the office, and it creates like a big blister. You can see these blisters right here. These are blisters that are caused by the laser, but then it doesn't hurt afterwards. That's the benefit. And the blister might hurt a little bit, but it's a lot less painful afterwards, but you have to really be strong during the treatments. And then occasionally we do salicylic acid. This would be more on a child or one that I think is almost gone. And then I'll put a little salicylic acid just to make sure, but it's not very effective as a standalone. And then there's Carac and Aldera. These are both used for other conditions, skin conditions, whether it be Aldera is used for other genital warts, and Carac is used for kind of skin lesions. And both of those are sometimes effective, and you can try those. For those that are being seen, for example, you're trying the over-the-counter, be careful. If you spent a ton of money on these salicylic acids, or if you spent money on freeze-aways and they're not working, come in to see someone. Be especially careful that you don't have a callus, because a callus can be mistaken for a wart and be treated a long time for a callus or something called a porokeratoma as well. We'll go over that. Next thing that's very common that people come in for would be an ingrown toenail. I just want to clarify, an ingrown toenail can be red and swollen and have some drainage on the side. But more commonly, when patients come in, if it's not infected, we see these ones all the time. They get referred in. And one of the biggest drawbacks is someone will go on an antibiotic, and then they'll be taken off the antibiotic. Then they'll go on the antibiotic and take it off. You need to remove that little piece of nail that's in there. Here's an example also, though, something that's really bothersome is with a painful callus in the edge. And that painful callus digs into the edge and causes pain to patients. And when you remove an edge of the nail, you can remove all that callus. The callus is really important when you're treating ingrown toenails. What are the causes? Basically, a nail is supposed to be normal and straight, but many times it gets ingrown. That could be caused by tight shoes, a thickened toenail, or a fungal toenail taking up more space. It can be inherited, trauma. You could hit it on something, or have a wide nail. Those are kind of some of the causes. Here's a quick review article. And here is what I recommend for people trying before they come in. So it's the things that are underlined when you're looking at these checklists. Okay, so you'll probably start by trying to pull down the skin. And basically what that means is if the nail is grown, you're going to tape from one side all the way down on the other, and that pulls down the edge a little bit. That can help. You can do some soaking in Epsom salt soaks. That can help decompress the nail. You can try changing shoes that are wider or wearing sandals. And then typically what happens is patients are on some cephalexin or clindamycin once or twice. But if that doesn't help, you really need to come in and remove the side of the nail. Okay, that's what you have to do. Just take out the edge of the nail. And for recurrent nails that keep coming back, there's a couple of options: Onifix, a matrixectomy, or a bone spur removal, if that's the case. I just want to show you a couple of these things. The traditional treatment is this one right here, this before and after picture. We take a little edge out of the nail, and then they come back in a couple weeks, and that's it. But if it keeps coming back, then we have to do either a matrixectomy or an Onifix. So matrixectomy is where we put an acid. In our office, we use sodium hydroxide. And it's right here. You can see it kind of going into the edge right here. And that kills the nail root, and it causes drainage for a couple of weeks. It's appropriate for people that have good circulation. One thing you have to really be careful of is you want to make sure that people have appropriate circulation when doing this. You don't want to mistake a foot that doesn't have enough blood flow for an ingrown toenail. That I've seen that a couple of times. Patients that have come in, they think it's an ingrown toenail, or they're referred for that, and it really ends up being a circulatory issue. And then the other type of treatment here is with something called Onifix. What Onifix is, if you look at this little white line that's on the nail, it's a resin that's attached to the toenail. Very similar to dental surgery. We use a light, a UV light, to cure it. We put it on there, and it sits on here. And then you can see the start, an ingrown toenail, after 24 weeks, and after 36 weeks, you can see we see patients back about every 3 months, and it straightens out the nail. Here's a really one you can see really curved, and it straightened it out. Basically, this sits on top of the nail, and as the nail grows out, this stays on. So this is a newer treatment. For those that don't like injections, that's a good option for them. Next, I want to talk about nail fungus. We get a lot of referrals for nail fungus, and there's a lot of kind of debate back and forth. What are the best types of treatments? Now, there's a lot of different types. Some nails have the traditional fungal look. Others are like gryphotic and very thick and look like ram's horns, we call them. Others are detached. You can see how this is elevated and detached, and some have this superficial white discoloration. There's a lot of different types of nail fungus. Here's another review article. This is the slide that I use for my patients when I explain nail fungus. Before I do anything, I just take a nail sample first, okay? But then when we talk about topical, I don't find topical all that effective. No matter if it's a prescription or non-prescription or Vicks or anything like that, I think it's effective about 6 to 20% of the time. I think a lot of times patients get a antifungal because they want something to do, not that it really works. I find it's really hard because you have to apply it for a year, and it's common to have incomplete cure. It might be okay for a very mild, like one edge of a nail or something, but I just don't find the great effects because it doesn't really penetrate in that well. I still find oral antifungal to be the best way of treating nail fungus. I do take a nail sample first. Now, I do a little bit different of a treatment of the oral, okay? Once again, I tell patients 60 to 80%, and patients, we do this all the time. If the nail has had a lot of trauma, though, or it's been injured, or it's really, really thick and dystrophic, sometimes it might clear out the fungus, but it might not clear the nail. Another problem is these fungal nails can grow very, very slow. I tend to put patients on biotin, and I have them take this medication starting for 3 months, once a day. And then what I do is I put them on it for once a week for another like 30 pills, which would be another 30 weeks. And then I see them back again. And if it's still not better, then I will put them on another 3 months. So the biggest problem, in my opinion, is the high recurrence rate and also the incomplete cure. So you start treating it and then it reinfects it before it totally resolves. I do get a liver test. I get a liver test just prior, and if everything is fine, then I don't repeat that. So yeah, that's what I do. I do a LFT prior. Now laser, I put 60 to 80. I don't know. I think it's more towards the 60. I wish laser was as effective as oral medication. If it was, everyone would get laser, but I don't think it is. We have 2 different lasers in our office, and I still don't think it's as effective. Maybe it will be in the future. We do 4 treatments. It's about 60% effective. Patients, we do before and after pictures so they can see it. The price is the challenge. It tends to be quite expensive, but for people that either aren't good candidates for oral medication or they don't want to take medicines by mouth, you can do the laser. Okay. And then nail resurfacing. This is kind of a neat treatment. If you look at this picture on the bottom, this ugly nail, and you put this, I don't know, this fake nail on this. This is a resin that we put on. It's called Cariflex. Patients love this. This is for people that maybe had ingrown toenails a number of times, and they have I call it the diving board nail. So if the nail used to be this thick, but now it's missing part of it, it looks like a diving board. And I put this on there, and they look beautiful. They can have it for 3 or 4 months. This is done right in the office. It's a cosmetic procedure. Patients love it. And then finally, removal. You could just remove the whole toenail and start over again. I try to avoid doing that because what happens is at the tip of the toe, what happens at the tip is that the skin kind of grows up and they get this bulbous change at the tip of the toenail when you remove it. But sometimes you can get the toenail to resolve with removal. Okay. Let's go now to talk about plantar fasciitis and plantar fibroma. I'm not going to spend too much time about a plantar fibroma, but I'll explain a little bit of the difference. A fibroma is a slight tear where it's gotten thickened in the bottom of the fascia, but the plantar fascia is a ligament that goes from the heel to the ball of the foot. The main thing we have to understand is that it's inherently associated with our posture, with our pelvic position, with a tightness everywhere else, most commonly the calf, and a equinus or a tightness in the calf muscle. So all of the focus is going to actually be on the calf and less is going to be on the foot. Okay. So when we talk about it, here's a couple of review articles here. When we talk about it, how would you start treating plantar fasciitis for patients? You can get an x-ray. Now, do bone spurs show anything? They don't. A bone spur, there's a Wolff's law, which says if a ligament or a tendon pulls hard enough on a bone, it's going to create a spur in that direction. So if they've had tightness for a long time, both in the fascia or on the Achilles, it could create a bone spur, but we don't treat bone spurs. We don't remove bone spurs anymore. I actually find a diagnostic ultrasound is much better for determining this, but a lot of you don't have access to that because what it'll show is the thickness of the fascia. The thicker it is, the more challenging it is to treat, and you can also see if there's any areas of inflammation inside. So how would you start treating it? This is what most patients try. They try icing and then anti-inflammatories or contrast baths. What I recommend, I like contrast baths. If they haven't tried it, they do a bucket of ice water and a bucket of hot water. You could do a minute in ice, minute in hot, minute in ice. You go kind of back and forth 4 or 5 times. And you could do physical therapy. I really think that's effective towards the plantar fascia and stretching out the calf. I like home therapy. So home therapy could be like some type of a foam rolling or a scrape or something to scrape the back of your calf. Stretching is a really good way to start. I tend to find a lot of patients, they'll try like purchasing night splints. They try all these things. So let me explain. A night splint is only if you have pain getting out of bed in the morning. That's what the night splint is for. I find that the stretching is really effective. But if you've tried stretching, if you've tried foam rolling, if you tried icing, anti-inflammatories, and it's not getting better, it probably won't get better on its own. That's the challenge. You've tried supportive shoes. You may even try some over-the-counter inserts or tape the foot. You can try these things. The things that are underlined, you can try. But if they're not coming in, I would come into the office because it just speeds up the process, especially if it's been over 3 months. I find many times patients come in having it for a year or two, and they're just kind of struggling with it. So don't wait for sending people over for plantar fasciitis. We have a lot of different treatments. Shockwave is the most common thing that we use these days. We are still doing some cortisone. I put 8 weeks because I don't like to repeat them for at least 2 to 3 months between the cortisone. And we have a lot of other things that we can do for patients. But for the most part, these are the treatments that I use for my patients with plantar fasciitis. But it's not getting better. It tends to turn more chronic, and you need to see someone about that. It's just not going to, just giving it more time might not be the best way. Okay. This is an example of the shockwave that we use. Basically what this is it's a bullet that goes back and forth, hits this piece of metal, and we hit the area of the plantar fascia or the Achilles tendon or any other tendon. What it does is it takes a tendon or a ligament that's chronically inflamed, it injures it, and it creates a cellular response of neogenesis, of producing vascular neogenesis, of a new blood flow to the area, and it produces all these like chemicals, these substances within it to help it to repair. So basically, the way I explain it to patients is you take something that's chronically inflamed, you injure it, and it make it acutely inflamed, so your body can heal it. That's how the shockwave works, and it works very well for a lot of these chronic issues. Let's talk a little bit about forefoot pain or pain to the front of the foot. This is something that you see all the time, people that have pain to the front of the foot. Here's an example. This might be due to like a hammer toe, might be due to a plantar plate, could be a callus, could be one of the tendons, could be the sesamoids. There's a lot of things that happen to the front of the foot. It might be kind of challenging. The more obvious ones would be a callus or a wart that you could see, but if it's underneath the skin, it's a little bit challenging. It's called metatarsalgia is the technical term. So it could be a stress fracture, bone swelling, plantar plate, the length of the metatarsal, metatarsalgia, hammertoe, the biomechanics. But to keep it simple, if someone has forefoot pain, you can get an x-ray, see if anything's obvious. For example, stress fracture. Many times I find patients coming in, if the x-ray has gotten too soon or the radiologist doesn't see these all the time, it's really a kind of a almost more like an art to find a stress fracture, and that's usually in conjunction with your exam. So you'd want to use like a tuning fork to put vibration over that area as well. Sometimes I'll even put a marker, a little metallic marker. I have basically a piece of wire I tape to the foot to show where it's hurting, so that the radiologist can look directly on that area. Those are a few tips with the X-rays. To start, once again, I would start over here. I would start with different shoes, and maybe strapping of the toe, like pulling the toe down with tape. They can try different types of pads. Shoes are key. Okay, the most common shoes that we're using these days for cushion are Hoka's. Hoka 1-1 is a very good shoe. And then also we're using a lot of anatomic shoes. So those are shoes that are bigger or wider in the front, like your feet are made. A couple of those brands are Topo and Ultra. And for those that are in Massachusetts, if you're watching, there's a couple of local stores would be like Sneakerama, which is in Worcester, and then there's Marathon Sports, which is right over in Shrewsbury. And for dress shoes, I recommend Panza shoes there in Framingham. So there's a couple of local stores that have these. You could try some physical therapy. If you don't really know the diagnosis, it's hard to try physical therapy for this. You can try anti-inflammatories, icing, strapping the toe like we talked about to kind of hold it down. But if it's not getting better, the shoe usually is the first thing I change, the shoe and an over-the-counter insert. When you're looking at inserts, don't just get the Dr. Scholl's ones. I would go to the running store and get one of the inserts that's in there. You pay a little bit more, but it tends to work better. It gives you more support. You don't want one that's going to bottom out when you step on it. Part of the forefoot pain would be like a neuroma. A Morton's neuroma is the most common one that people know. If you look at this image, you can see there's different nerves going to the different toes. And specifically, this nerve right here is very swollen, and that is a example of a Morton's neuroma. It tends to happen between the third and the fourth metatarsal because there's more movement in the foot in that position. If you look at like a foot skeleton, there's just more movement in that area, and it can pinch the nerve and get swollen. Typically, patients complain of they feel like they're walking on a sock, or they have a fullness in the front of their foot. That's what they're kind of feeling. The treatment, there's different types of treatments for this. To start out, I would start with an X-ray to see if make sure there's no stress fracture. I would do icing. I would do anti-inflammatories. Then once again, anatomic shoes. Those are wide shoes like we just talked about. If that doesn't work, then you could try a cortisone injection, or I tend to do an ultrasound first, measure the size of it, see if there's inflammation around it, and then you could try some other type of treatment. Cortisone tends to work well, but shoes are the key. Trying an anatomic shoe to start is really important. We'll talk about foot fractures. We see a lot of fractures. A lot of times the primary care team will treat those, and we tend to see the ones that don't get better or they're just unsure. To start out, we always get an X-ray, and then we get serial X-rays. Depends, usually every 2 weeks. For a lot of people, if they're walking on it, I would do icing and anti-inflammatories, some type of compression if there's a lot of swelling. So either a Coban or an Una boot. You could also strap the toes. You could take some 1-inch Coban, and you can wrap the toes to each other. You tend to want to do the larger, whatever's fractured, you do the bigger toe next to it. And that's how you strap them. You could put them in a surgical shoe or a surgical boot if you have access to that, and then crutches if it's really bad. And then we tend to see the ones that are challenging, that aren't getting better, where we might use a bone stimulator, or they'll need some type of a surgery for it. Fractures tend to heal pretty easily. Stress fractures are the ones that are a little bit more challenging to determine if you have a fracture or not. If you're unsure, I would send them over because it could be a lot of other things as well. We'll get into like the bunion aspect. So here is example of a bunion, and this is an example of a tailor's bunion. So a tailor's bunion is on the outside, a bunion's on the inside. And here's some pictures. Here's a review article for you. How do I start with this? Well, I start with an X-ray, and then once again, going back, it's these anatomic shoes. If you notice, one thing we pretty much spend most of our time talking to patients about is anatomic shoes, okay? They can also try a couple of toe spacers. You can buy correct toes over the counter. Those are another type of a toe spacer, or a bunion pad. If that doesn't work, usually it's because they're not willing to wear the shoes, or the bunion is too big. You could try some physical therapy. I don't find physical therapy helps all that much for bunions itself. But if it's not getting better, then you may want to send them over, and we could, a lot of times we're just the bad guys telling them to switch their shoes, or being the ones to say, well, maybe you should consider some type of a surgery for your bunion. Okay. Achilles tendinitis. This is very similar to the treatments for plantar fasciitis, because they're both inserting into the heel. So basically you look at it's the same thing. The only difference here is that patients do with Achilles or a Haglund's deformity, which is a bump on the back, they'll do well with a heel lift. So consider a heel lift in their shoe, not just a shoe insert, but an actual, they can just buy an over-the-counter heel lift. You could try an arch support, or an over-the-counter orthotic support of shoes can be helpful. Of Achilles tendinitis, you want to avoid going barefoot and avoiding a zero-drop shoe. What a zero-drop shoe is are these shoes now that don't have heels on them at all. They're basically like you're walking barefoot. They're good for a lot of people, but if you have a tight Achilles, it's going to make it worse. You can also try some physical therapy, home therapy, like foam rolling, icing, anti-inflammatories. I would get an X-ray to make sure there's no bone spur there. And then when they come in, you do the other things, the diagnostic ultrasound and the other types of treatments for them. This is something that responds very well to that shockwave that I talked about before. Diabetic foot. We see a lot of referrals from diabetic feet. Everyone wants to know when they should send, or what diabetics should be seen by a podiatrist. I always recommend a podiatrist is very similar to an optometrist or ophthalmologist. They should be seen once a year, basically. If there's no symptoms, it's just once a year. Then based on the symptoms, then I see them more frequently. For example, if they have profound neuropathy, or they can't feel, and they have poor blood flow, then I'm seeing them every 3 months, and I'm trimming their nails, doing their calluses, doing a foot exam, doing a comprehensive foot exam to make sure there's no problems, and then dealing with any of the issues like the wounds and things like that. Patients should be reviewing their feet every day, examining the bottom, looking for any cracks, and then telling someone if they have a problem. Okay, but at a minimum, every diabetic should be seen once a year for a foot exam. We'll educate them. We'll see them back yearly, because right now it might be fine, but in the future they're going to have, everyone pretty much has some type of an issue over time with the diabetes. What you can do, you can get, if you have any concerns, you can get x-ray. The big concern we have is something called Charcot foot, where the foot would kind of collapse, but you would notice a red hot swollen foot. You would get an x-ray for that to make sure there's no broken foot. That tends to be in neuropathic patients. Compression socks, if they have swelling, I tend to recommend vascular studies. The way I do vascular studies is diabetics over the age of 50, I do ABIs on them because there's a lot of PVD, that can be peripheral vascular disease, that can be missed. Doing shoe recommendations. I think shoe recommendations are important for my patients with diabetes. Not everyone needs diabetic shoes, but everyone needs shoe recommendation. Then we'll do the Sems-Weinstein, the vibratory, and the pediatric foot exam. So there's a lot of these things you guys can do. A 5-minute foot exam, it's pretty easy, but I'm shocked with how many don't ask to take their socks off. Diabetics, most doctors do. They ask to look, but if you see anything, just send them over. Okay. Let's talk a little bit about flat feet. What do you do with flat feet? Do all flat feet need to be treated? Do kids' flat feet need to be treated? Not all flat feet do. They tend to put extra work on the tendons, especially the posterior tibial tendon, which would run right here. Down here, it gets overextended. And when you look at them from the back, the heel goes out. That's where you can tell a really flat foot. This type of a foot would benefit from an orthotic. Okay. How do you start treating them? Well, you first start with supportive shoes, and then you go kind of into a walking boot. If the tendon, like this posterior tibial tendon, that's what that PTTD is. If that's really inflamed, you put them in a walking boot. I get x-rays. You can do anti-inflammatories, stretching and foam rolling, physical therapy. If it's not getting better, send them in, because they may need like a brace, or they may need an orthotic or something else to calm that down. And then, if things aren't getting better, then there's other types of treatments. But initially start with the shoes and some type of an insert in their shoes, just an over-the-counter insert. Pediatric flat foot, much the same. If you are concerned, if the parents are concerned, send them over. Once again, we just start with supportive shoes, an over-the-counter insert. We can do custom inserts. And then a lot of could be the tightness in the calf as well. Cysts, these happen in different areas on the toes. They usually come from either a tendon sheath or a joint. What I recommend, and I usually get an x-ray, and I'll put a little metallic marker when I do it, so I can see exactly what joint it's coming from. I'll do icing and anti-inflammatories. And then I will aspirate. If you feel comfortable, you can aspirate, pull out the liquid, and then I do compression with like 1-inch Coban or 3-inch, depending on where it's on the foot. I kind of use the example with you have a balloon, like your kids are playing with a balloon and they blow it up and they let out the air, and then you try to blow it up again, it's harder, and then it's harder every time you try to do it. And that's how the cysts are. Hopefully you can pull out the liquid a couple of times and it won't fill back up again. Occasionally we have to remove them, but it's not all that common. Gout, you guys see gout all the time as primary cares. We see it when you refer it over. A lot of times you are treating it. When someone comes in with gout, though, what I tend to do first line is do a cortisone injection into the joint, as long as we're sure it's not an infection. But you could try prior, you could get a uric acid. A lot of times it's trending down, though, by the time you get that uric acid. You can do icing, anti-inflammatories, prednisone, put them in a walking boot if it's painful, x-ray or an MRI to rule out any infection. But ultimately, I just do a cortisone injection. It really, really helps them to feel better. Okay. Haglund's is very similar to Achilles tendinitis. It's involved where the Achilles inserts into the back of the heel. They have a big bump in the back. This can be painful. There's a lot of treatments you can do to start with contrast baths, icing, stretching and physical therapy, foam rolling. Once again, a heel lift can benefit this, a supportive shoe, and then x-rays to evaluate that bone spur. But the Haglund's is quite common as well. The next thing would be Hallux limitus. Hallux limitus can have a bunion, but a lot of times what happens, it's just injury into the joint region, like arthritis in the joint. Arthritis in the big toe joint, I start with like icing, anti-inflammatories. Physical therapy, be careful though. If the pain is in the joint, you don't want to move that joint too much. It could actually make it worse. If the problem is shoe gear, anatomic shoe gears can help. And then some type of a rigid shoe. These types of patients tend to feel better in more of a rigid shoe that doesn't bend. And then certainly getting an x-ray. If that doesn't get better, cortisone tends to help, or an orthotic, and there's other types of treatments we can do as well in the office. Hammertoes, here's some bad hammertoes. Here's some hammertoes after surgery. There's different types of hammertoes. The main thing I want you to realize is that there's flexible and rigid. If your hammertoe is like this and you can't straighten it, it's because it's developed arthritis already and it's rigid. If you can straighten it, then it's flexible, and then that's easier to treat with just doing a little tenotomy in the office if needed. Not all hammertoes need to be treated with surgery, but that's kind of the distinguishing factor. But to start, once again, going back, it's anatomic shoes. If you hear that over and over again, we spend most of our time telling people to buy shoes. So to review, there's a couple places in town, a couple of brands like Ultra, Topo, Lems. Those are some of the brands. Correct Toe's website, correcttoes.com. They have these toe spacers, but they also have a great selection of shoes there that patients that are anatomic. They might not wear the spacers, but they could try those shoes out. So that's what I always start with that. And then if it's too painful and it doesn't get better, then we can do the surgical repair. Tendons on the outside of the ankle, the peroneal tendons, they very commonly get injured, get inflamed. They can get inflamed at the insertion point of the fifth metatarsal or back where they do the curve. It's because of the curvature here, they can get torn. We start with usually an x-ray to see if there's anything else we're missing. We actually do ultrasound more than we do MRIs, but you could try an MRI. Icing, stretching, physical therapy, once again, to loosen up the tendons. Ultrasound will tell me if there's any effusions around there. And then we tend to go right towards shockwave, but you could try supportive shoes, maybe even ankle brace first, or a compression sleeve, like one of those neoprene sleeves around there. That's quite helpful. Pain in the bottom of the big toe, which would be the sesamoiditis. These can be painful. A lot of times they can be from dancers or people that are doing a lot of walking. I recommend starting with an x-ray to make sure that there's no fracture, make sure there's no two-part bone. There could be a bipartite sesamoid in there. And then you can ice, anti-inflammatories, kind of a supportive shoes. Stretching doesn't really do too much. If you have a really tight calf, it can increase forefoot load. So you want to stretch and loosen the calf out. But basically, I put people into a walking boot with a cutout underneath that area. So I offload that area. And then if that doesn't get better, we'll do either shockwave or a cortisone in there. Sever's disease. We see a lot of patients every year. These tend to be younger children, 9, 10, 11, 12-year-old, pain in the heel, usually due to a really tight Achilles tendon, and it pulls in the growth plate. That's called calcaneal epiphysitis or Sever's disease. To start, getting an x-ray will just verify that the growth plate is open. Icing and anti-inflammatories. Stretching and foam rolling is key, and physical therapy is key. So they can start that before they see us. You can try different types of heel cups. There's something called a Thule's heel cup. Or a heel cushion. A heel lift as well can take some of the pull off the Achilles, and then kind of supportive shoes can help. Send them in if they're not getting better after you try that. There's some other types of treatments. You could do turf toe as well, which is very similar to that Hallux Limitus I showed you before, but this is from jamming in the toe joint. Just usually this is abrupt coming from playing a game or some type of a soccer game or something like that. To start with that, getting an x-ray, icing, anti-inflammatories, we put them in a walking boot. If you have access to them, put them in a walking boot, rest them up, and or in a really rigid shoe or a boot. And then if that doesn't get better, cortisone injection. Wounds are kind of beyond the scope here of what you can try, but you can try some. I would recommend getting an x-ray if you're concerned about bone infection. I would put them in a surgical shoe at a minimum, have them stay off their foot at a minimum, and treat the infection, and then send them over to see a specialist if it's not healing. Basically, it should heal in 2 to 3 weeks, and if it's not, it's probably because they're walking too much on it, or there's some type of deeper infection, or they don't have blood flow. We tend to test the blood flow. We check the blood sugar, all these things to get them to heal. It's very complex, but we'd be happy to see or help or collaborate in any of these. Once again, if you found this helpful, you can download the presentation. I'm also going to put in the presentation just a few links here for you that could be helpful. Okay. Once again, hope you guys enjoyed this. Okay. Have a great day.